right, so we'll go ahead and get started on, cardiovascular emergencies part two. This last little section of it, but this is, we kind of did a lot of anatomy physiology review. Now we're going to just keep jumping into pathology. Oh, cool, and I put the intro slide on the wrong one. So we left off with acute myocardial infarction, okay? So acute myocardial infarction is what it sounds like. So acute, rather sudden, myocardial. Remember, this is the muscle of the heart, the skeletal or the cardiac muscle of the heart. Infarction. Remember, infarction is when cells die. Okay? Ischemia, they're screaming for oxygen, they're starving for oxygen. Infarction, they have died. So, pain of an acute myocardial infarction signals the actual death of the cells in the area of the heart where blood flow is obstructed. Okay? And so we can do this thing, you don't necessarily memorize this, but called angioplasty or percutaneous coronary intervention. And this is by far the most effective treatment. So basically, you'll have a vessel, right, that's all clogged up. Well, it's clogged up like this. Let's just imagine this is like some big clot. Well, what you can do is you can take a tool through the patient's like wrist or groin, and you can draw like literally like a camera, like a tool, and you can come in here and you can, like the Chinese finger traps, if you twist them the other way, how they get wider. Well, you can do that, and that's called a stent. And so it'll open up this area right here, right? So it's called a stent. And so you open that area up, and then that's the long-term treatment. What you do first is use a balloon. That's called angioplasty, and then you can use a stent to open it up and open this area up. So this is very effective. This is called a cath lab procedure or heart catheterization, right? So catheter is when you insert something through a sheath or like through a. So this is common. Okay, we do this a lot. We'll call the hospital. Hey, we have a patient with a heart attack. They'll look at them, do a couple tests. Sometimes they don't even do the test. They'll just take what the paramedic said in their test and just take them straight to the cath lab to do angioplasty or percutaneous coronary intervention (PCI). So these are very effective. Okay, these are done obviously by very skilled cardiologist inside a cath lab. Now, the signs and symptoms of an acute myocardial infarction is kind of what we hear about on TV, right? Like sudden onset of weakness, nausea, and sweating. What's the medical word for sweating they'll use? Diaphoresis, okay? Now, keep in mind, when you see a patient in the world, if it's 110 degrees outside and they're sweating, okay, that's normal. But if they're pouring sweat and it's 70 degrees in the house, right, like that's diaphoresis, okay? It's a sign of hypoperfusion. You see that in shock. Now, chest pain, discomfort, and or pressure, right? So they can describe it in all those ways. Remember our OPQRST, onset, provocation, quality, radiation, severity, and time, right? We use all that to put together the pieces of and qualify and quantify their pain, okay? And then they could have, pain or discomfort or pressure even in their lower jaw, arms, back, abdomen, or neck, okay? Remember, the innervation in this area is fairly nonspecific, and so sometimes we'll have referred pain, right, to where it feels like it's up in their jaw or their shoulders or their arm or their back or their neck. So that happens. You can have an irregular heartbeat, so you don't need, well, I'll tell you, what happens is when the heart gets irritated, remember that whole automaticity thing? There's a thing called plasmatrophy, where the bottom of the heart, or really any part of the heart, can be irritated and just be like, and just like scream real loud, and it'll make that part of the heart beat, and that's called a premature contraction. So you can get an irregular heartbeat from an irritated heart. It can cause, that's one of the arrhythmias it can cause. It can cause lots of arrhythmias, but that's the most common. Or syncope. Remember that word syncope, not syncope. Syncope means the medical word for fainting. Okay, you could get fainting from arrhythmia or from cardiogenic shock or anything like that. And then we'll keep going. Shortness of breath or dyspnea. Remember, dyspnea is the medical word for shortness of breath. And then pink frothy sputum. That's interesting. So remember, sputum is stuff that you kind of you like the stuff in your mouth, right? Like spit or whatever. Well, pink, if it's pink, it's blood tinged sputum. So what happens is in heart failure, we're going to talk about which one, it's left side of heart failure, can end up backing up blood that'll cause this pink frothy sputum. Okay. And then you get a sudden death, right? Like it's very common for these patients just to drop dead. Right? These are the people that are like, oh, my chest, grab their chest, and then boom, they're dead. Okay? This does happen. It's not just the movies. That really does happen. So the most common symptom is chest pain. Okay, who didn't see that coming? But acute myocardial pain differs from angina pain in three ways. Okay, acute myocardial infarction can occur at any time, so it's not necessarily, oh, I have this severe chest pain when I walked up the stairs. It does not resolve within minutes, okay? And it may or may not be relieved with rest or nitroglycerin. So what does that sound like, right? That sounds like this is severe. We can't get it to go away. It came on sudden, right? It sounds severe. And that's because this is the most severe form of this, right? This is an acute myocardial infarction. This is very, very severe. Obviously, this is incredibly lethal. And so we treat this, okay? Now, the physical findings. What does the patient appear? The word I used earlier, right? They'll have a sense of impending doom, right? Like they feel frightened. They feel like, oh my God, something is wrong. Like they know. I've told you this before. If a patient tells you, I'm going to die, you better believe them, right? I've had that happen like many times. They tell you, I'm going to die, they do, right? And they're serious, right? Like, do you know, right? So an impending sense of doom, they feel like they're dying. They're very anxious. They're very frightened. Their pulse will increase. Okay, that's one of the hallmarks of cardiogenic shock. Or really most shocks, but it does increase. The blood pressure could fall. Remember, that's a late finding, but you'll have a decrease in blood pressure because of decreased cardiac output. Okay, well, that's one of the reasons. And then difficulty breathing. What's the medical word for shortness of breath? Dyspnea, right? Overwhelming feeling or impending doom. That's the word they'll use. Impending doom. Like they feel like they're going to die. Like they feel doomed. Now, the consequences of acute myocardial infarction is sudden death. That's usually from arrhythmia. Okay, so their heart will go into some bad beating arrhythmia and they'll end up dying. And I'll show you what that looks like. Cardiogenic shock. Okay, so the heart, they'll have low perfusion of the body, and so that's shock. But since the cause of the low perfusion is the heart, we call that cardiogenic shock. Okay, heart failure we're going to talk about coming up too. So the heart has failed. You have a pump that has failed. So what does that look like, right? It looks like heart failure. So you don't even memorize these. Do not memorize these. You have these lethal and non-lethal dysrhythmias or arrhythmias. Those are fairly interchangeable. And so, I mean, there's one on, I left the slide in here, but, this is a pretty normal 12 lead right here. I mean, it's actually, or not 12 lead, I'm sorry. That's a EKG. That's normal actually right here, okay? That's what it's supposed to look like. It doesn't take a genius to realize that this is incredibly bad compared to this, right? This is incredibly bad compared to this. I'm telling you this is normal. You could not be a paramedic and be like, well, this certainly doesn't look like this, and this certainly doesn't look like this, and this is like completely dead. This is a systole, right? So these are pretty obvious. Don't memorize these, right? Yeah, this is way is complicated. But what I'm saying is these are what you need to know is the most common cause of death of acute myocardial infarction is cardiac arrhythmia. Okay, they go into arrhythmia, usually one of these two, and they die. It's usually almost always how it happens. If they die, it's because of one of these two. Now, and actually, these are both treated with an AED, by the way, in CPR. These are the only rhythms that AEDs treat. Fun fact. So, cardiogenic shock. I just talked about this. What's shock, right? Hyperperfusion of cells, low perfusion of cells. And so, what happens is when we have low perfusion of cells because the heart, that's called cardiogenic shock. So, this could be for a lot of reasons, right? The heart rate's really slow. The heart rate's too fast, so arrhythmia. There's not enough pump within the heart. There's not enough force pumping blood out, right? Heart failure could cause cardiogenic shock, right? So there's a lot of reasons we can get cardiogenic shock. But mainly, this is caused by a myocardial infarction or past myocardial infarction. So, how we can differentiate cardiogenic shock from something else like hypovolemic shock is a good patient history, right? So if the patient tells you, oh, I haven't had any nausea, vomiting, or diarrhea, I feel hydrated, and I haven't been bleeding, well, that's pretty good indication it's not hypovolemic, okay? So we can take the chief complaint along with the heart rate. You'll see an increased heart rate in both of these usually. And then peripheral edema. I'm going to show you what this looks like, but peripheral edema means swelling of the periphery, right? So swollen hands, swollen feet, swollen butt, right? Or sacrum, really. Dysrhythmias, we've talked about that. Jugular venous distension, I'm going to talk about what this is. but this is when the necks or the veins in your neck get engorged. We'll talk about why. And then crackles on auscultation and breath sounds. We've heard that word crackles. What's the other word for crackles? Rails. So basically, you end up with pulmonary edema, and that sounds like crackles within the lung fields. Okay, it's like breathing through a sonic cup with like ocean water in there, and so it sounds like they're breathing underwater because they are. They're breathing through edema, and so pulmonary edema, and so the same initial evaluation and treatment as any patient reporting chest pain, right? So like it's the same. We do our across the room assessment, general impression, primary assessment, reassess, secondary assessment, reassess. So we go through those same steps, but you know, things we look for, again, they're saying a lot of the same thing, right? Anxiety or restlessness, impending doom, right? Air hunger. What's air hunger? They just can't get enough air. They're just hungry for air, okay? Pale, clammy skin. If it's pale and clammy, what is that called? Diaphoresis. They are diaphoretic. High pulse rate. What's a high heart rate above 100 called? Tachycardia, okay? Rapid and shallow breathing. What's fast breathing called? Tachypnea. Nausea and vomiting, right? A decrease in body temperature, that's marginal. We wouldn't get stuck on that. Hypotension, so their blood pressure is 80 over 40. It's very low, right? That's a problem. Okay. So the treatment for this is interesting. And we use the advanced EMT books. I think it's a little better than the EMT book, so we'll take that out. But, you put them in a position of comfort. So, question, is this patient going to want to lay flat on their back? No. So we put them in semi-Fowler's or Fowler's position. Remember, semi-Fowler's is kind of sitting up. Fowler's position is fully sitting up. Um, and then you'll maintain the oxygen SpO2 through the pulse oximetry greater than 94%. So a lot of times these patients do get a nasal cannula, okay? 1 to 4 liters of a nasal cannula. If you see it on a test and they say the patient's breathing 96%, do we put oxygen on them? No, you do not, okay? Well, sometimes, especially as they start to die, we'll have to assist their ventilations as necessary with a BVM. Remember the thing we put on their face and we squeeze it, right? That's a BVM. We preserve their body heat. It's not, we'll put a blanket on these patients, of course. Transport rapidly. Don't be messing around on scene for 30 minutes doing a bunch of nonsense garbage. Put the patient in the ambulance. Go. Go to the hospital. We are in the business of taking patients to the hospital. At the EMT level, put them in the ambulance and go to the hospital. That's what we do. We're very good at that. Call for paramedic backup if it's available. The reason that is we can give them more medicines. Paramedics can give them more medicines. And if they go into arrhythmia, we can fix it. You usually cannot as an EMT. Okay, I'm not hating on EMTs. I'm saying your scope of practice is a lot more limited because you're going to school for 16 weeks. Paramedics go to school for 2 years. So I encourage you to go to paramedic school. You get to do a lot of cool things. Now, heart failure. So think of any pump, a fire truck pump, a pool pump, right? A pump, a well pump, right? It's moving fluid, right? It's pumping fluid, okay? And so the heart is a pump. It's a complex pump. And so the pump is failing. And just like if I were to go out to your pool pump and start beating on it with a baseball bat, right? And cracking the housing and breaking the fins and the fan, right? It's not going to pump as effective. And that's pump failure, right? And or I reduce the electricity going like from 20 amps to 10 amps, or I don't know those numbers, but I decrease the electricity in half, right, of your pool pump. It's not going to pump very effectively. Or I decrease the RPMs of the pump. It's not going to pump very effectively. And so the same thing happens in a human heart for a variety of reasons. And we coined this term heart failure, okay? And so what they define, heart failure, ventricular myocardium, so the bottom part of the heart, the muscle at the bottom of the heart, can no longer keep up with the return blood flow from the atria, okay? And so the pump has been overwhelmed, so it starts failing, okay? And so, this can occur for a variety of reasons and really any time. But most commonly, what we see in the United States is because of, well, this happens a lot of reasons, but you'll see this a lot on exams, I should say, after a myocardial infarction, after a heart attack, right? Acute myocardial infarction, heart attack, all the same thing. Just heart attack is a slang word for it, a layperson's term. It's not the medical term. What you'll see, is heart failure. And I've drawn this for you guys. Like, if this is your heart and this chunk of the heart died, right, from a big old heart attack, well, of course, your pump's not going to work very well anymore. Because remember, when heart tissue dies, it turns hard and sclerotic. It just turns into like a white mass, right, like a white piece of muscle that doesn't do anything because it's dead. And so that is the problem with heart failure, right? So you could have long or heart valve damage. Remember me talking about aortic stenosis or aortic regurg, mitral stenosis, or mitral regurg, right? Like regurgitation, by the way. Um, if your valves get jacked up, it of course it messes up your pump. You could think the same thing in a fire truck or a pool pump, right? Like if I start jacking up the valves of this pump, is it going to be as effective? No. The same thing happens in a human heart, right? And then long-standing high blood pressure. Well, what happens in this is there's a few reasons. Namely, is it'll hypertrophy, right? So like, so the muscle will get thicker. So what happens is, disregard that. If this is normal heart, right? And so this left ventricle has to pump for years with over a high blood pressure. It gets really thick. And as it gets thick, you can eventually decrease the lumen of the ventricle, like the space in the ventricle. And that can create a type of heart failure. But that happens actually a lot in the United States when this gets really thick like this. And so instead of having this nice big ventricle that was like nice and open. Now it's just like this little bitty ventricle because it's gotten so thick to pump. The heart can hypertrophy. Just like if I were to go to the gym and do 1,000 curls, right? My muscle will eventually grow and get bigger. Well, the same thing happens to the heart. It's a muscle. So if you put it under stress, it will eventually start getting thicker, right? Hypertrophies. So what's hypertrophy? Same number of cells, they just get bigger. Okay? That's what happens in your skeletal muscle and in your cardiac muscle. Now, heart failure. Let me say this. Typically, almost always, when we see patients in the pre-hospital environment, they have something called congestive heart failure, meaning both sides of the heart are now jacked up. Okay? That's very common. Like we see that a lot. But annoyingly, on exams, they want you to know the difference between, well, what happens if just the left side of the heart fails? And what happens if just the right side of the heart fails? That does happen, but it's not for a very long period of time because if one side fails, the other side will also fail. Like it's obviously a pump that works together. So, I'll recapitulate this, right? Typically, we see a condition called congestive heart failure, meaning the whole friggin' heart is messed up. It's failed, okay? But your book, academically, clinically, right? There is a distinction between left-sided and right-sided heart failure, but it's not like super important. For now, to get through these exams, you do need to know the difference. But I'm telling you, in the field, you typically you don't typically need to distinguish between these because you'll just look at the patient like, oh, they have heart failure. It doesn't really matter too much if it's left or right in the field, but on exams, it really does matter. So let's talk about this, okay? So left-sided heart failure is the most common, and so what happens is the left side of the heart is the thicker side of the heart, right? And so it can be damaged for a variety of reasons, right? You could have a big old heart attack on that side. Of course, the muscle dies, becomes sclerotic, right? You could have heart valve disease, again, aortic regurg, or aortic stenosis, mitral regurg, things like that. Or just high blood pressure. And I demonstrated on the previous slide what all that looks like. And so what happens is that the heart, like the pump fails, okay? And so you'll get this heart rate increase and left ventricle enlarges to increase the amount of blood pumped each minute. You're trying to increase stroke volume and cardiac output, okay? And so when this happens, this will lead to congestive heart failure. And this is the most common cause of full-blown heart failure. And so, and especially right-side heart failure. And so what happens is, we'll just look into this. When your left side of your heart fails, where is the blood from the left side of the heart coming from? It's coming from the lungs. Okay? Remember, lungs you're pumping blood out of the lungs through the pulmonic veins, oxygenated blood, to the left atrium, to the left ventricle, and out through the aorta. Well, when that pump fails, it starts backing up. Okay? So you have all this blood that can't get pumped out quick enough from the left ventricle. It starts backing up. Where does it back up to? It backs up to where it originated, in the lungs. Okay? And so you end up with a lot of blood sitting in the lungs. And when it sits in the lungs, it creates a pulmonary edema. Remember, edema is just a fancy word for swelling. So you end up with lung swelling. You end up with all this fluid stuck in the lungs. And that creates a set of signs and symptoms called orthopnea, right? And what sound, when we put our stethoscope on the patient's chest, especially at the bases, when we listen, what sound are we going to hear with pulmonary edema caused by heart failure, left-sided heart failure? You're going to hear crackles or rails, right? So remember, crackles and rails are the same thing. It's going to sound like they're breathing underwater because they are, right? They're breathing underneath a fluid. right? So there's fluid in the alveolar space. And so, you know, what will happen is they get, pulmonary congestion, right? To where they will have rails and crackles, they could be coughing, they could have that pink frothy sputum. That edema can build up, this isn't a severe case, can build up so severe, it can literally, think about this, crazy, make its way out the windpipe, the trachea, and into their mouth. Pink frothy sputum. They have blood and like pulmonary edema fluid backing up into their mouth. It is falling out of their trachea. Very severe. You do actually see that clinically. That does happen. And so they'll get what's called pink frothy sputum or blood tinged sputum. It's backing up that far. The blood can't be pumped out of the lungs, so it just starts building up, and it'll eventually make its way up to the trachea, right? So of course they're gonna have tachypnea as well, right? I'm using this guy as the example. I think these drawings are always kind of cute and cool. Um, and so, of course, the patient's going to be restless. They're going to have cardiogenic shock, right? In acute case, cardiogenic shock, so they're going to be confused. They're going to have this fancy word right here called orthopnea. Remember orthopnea? They have shortness when laying flat. So what they want to do is they want to sit forward. So you're going to notice they're going to be leaning up. They will not lay flat. How do you know someone has heart failure? A lot of times you can ask them, how many pillows do you sleep with? If they sleep in a recliner, or they sleep sitting up, or they sleep with like 5, 6, 7, 8 pillows, that sounds like orthopnea, okay? Or you could do, I mean, we don't test this, but you could ask the patient, if I lay you flat, do you feel like you're going to get short of breath? And they're going to say, yes, I feel like I'll drown. You'll hear them, I feel like I'm drowning, right? Because there is fluid in their lungs. They feel like they're drowning. Tachycardia, right? Heart rate above 100. Exertional dyspnea. So they get short of breath when they exert themselves, when they walk to the refrigerator, when they walk up the stairs or whatever. Fatigue and cyanosis. What cyanosis is? Bluish tint to the skin. They're showing that you around his mouth and his toes and his fingers. That's called acrocyanosis. Now, that's left-sided heart failure. Okay, so what do you need to know as an EMT? Left-sided heart failure will present usually during or after a heart attack. It can be because of high blood pressure or heart valve disease. And what you will hear on an exam is the lungs will be congested. They will have cough. They will be coughing up pink frothy sputum, blood-tinged sputum. They will have crackles and rails in their lungs. They have orthopnea, meaning they can't lay flat. They get short of breath when they lay flat, right? That's left-sided heart failure. So think left lung. See what I did there? The L's, right? Left equals lungs. So there's fluid backing into their lungs. Left-sided heart failure, most common form of heart failure. As opposed to right-sided heart failure. Remember, these commonly go together, but right now we're splitting them apart. Right side, and yes, you need to know these. Excuse me. Excuse me. Right-sided heart failure. The right side of the heart has failed. Where does blood from the right side of the heart come from? It comes from the venous blood, right? So it's coming from the blood down at your big toe and the blood up in my brain. Deoxygenated blood is making its way to the right side of the heart. Well, think about this. If the right side of the heart can't pump effectively enough to dump the blood from the right ventricle into the lungs, because that's where it goes through the pulmonic artery, what's going to happen? It's going to back up in the systemic vasculature. So you end up with blood that gets stuck down in your vasculature. Okay, so it like builds up. And one of the ways this presents is it causes something called an increased hydrostatic pressure, which will then lead to a decreased oncotic pressure, like a decreased protein pressure. And so you end up with something called edema, right? Or peripheral edema, or dependent edema, or pedal edema. And pedal edema is, there's a pulse point right here called the pedal pulse. And so pedal edema means like feet swelling. And we see this really commonly because what you'll see is like, most people sit up during the day, whether they're in a wheelchair or chair or whatever, especially old people. And so gravity will pull the blood down there. And just like in the lungs, fluid will kind of leak out through the hydrostatic pressure. And so you end up with fluid leaking out into the third space. And so you end up with something called pedal edema, dependent edema, right? Or pitting edema. And so let's talk about what this whole pitting edema is. Pitting edema. Well, I've talked about this before. If you take your thumb and place it on the patient's, like right there where their pedal pulse should be, or on their tibia, right? It's usually where the tibia, like where the shin is usually where we do this. And you just take your thumb and you push down and you hold it for like 3 to 5 seconds and you let go. Normally, if there's not a pedal edema, dependent edema, you should push down and it should go right back to its original shape. But what you'll see is when someone has right side, well, it can have for a variety of reasons, but in this case, right-sided heart failure, what you'll see is they'll have what's called pitting edema. So when you shove your thumb into their skin and you let go, it's pitted. It leaves like a pit. And if you have an old relative, you could probably go up to them and do this and notice that it pits. And so what happens in this case is it's a hydrostatic issue, right? It's like a water issue. It's not like lymphedema. Remember, lymphedema is non-pitting edema. So their leg, this is like lymph node damage. You'll push on it. It's really swollen like this. You'll push on it, but it immediately pops back to its original shape. But when you push on it and it pits, it stays pitted. That's called pitting edema. And so this is a common cause of right-sided heart failure will cause this. So this becomes a problem, right? You could also see this back into the liver and into the stomach, right? So you could get something called ascites, okay? So you could get like hepatojugular engorgement, right? And so we could also see this back into the jugular veins. So we typically we have these veins, right, up in our neck. And if I were to sing some Adele or something like that, really let you have it, you'll see this in singers, right? Their veins get engorged, right? So you'll see these veins in their neck stick out. And I can't do it. I mean, I have to bear down for it to happen, but you know what I'm talking about. Everyone's seen this. And so sometimes the fluid, remember this venous blood, jugular venous veins, jugular veins, right? So when the right side of the heart's not pumping well, it'll literally back up into these jugular veins. So they become engorged. So they'll stick out. And we call that jugular venous distension. And that's what they're showing you here. And so, that's one way this present. You could also get weight gain. The weight gain's from them holding onto water, okay? Dependent edema, that's what they're showing you here. You'll get an enlarged liver and spleen. I just explained why. That blood, the venous blood, especially from the portal system, for a variety of reasons, but it backs up and it kind of will make the liver swell up. And there's a test you can do. We don't do this, but if you were to push on someone's liver with this, they have what's called hepatojugular engorgement. You push on their liver and their veins will get real big because you're like shoving blood out of the liver. So, and their heart can't accommodate that extra blood because it's failed. So, anyways, of course these patients are going to be fatigued. So remember, left-sided heart failure equals lung, right-sided heart failure equals the rest of the body, right? Like the rest of the body gets swollen, okay? So you do need to know the difference. Now, like I said, left-sided heart failure is the most common cause of right-sided heart failure. Both of these can be caused by heart attacks, hypertension. On the right side, it's pulmonary hypertension, right? So, there's different ways this presents. So, how this presents, general just straight up heart failure, orthopnea, the patient can be agitated, short of breath, chest pain, distended neck veins. Remember hepatojugular engorgement, I just talked about that. Swollen ankles from pedal edema. Remember we checked that for pitting pedal edema. They get a high blood pressure, high heart rate, breathing quickly, use of accessory muscle breathing. These patients will be short of breath, okay? Crackles, remember the other name for crackles? It's rails. It sounds like they're breathing underwater because they are. Productive cough and delayed capillary refill time. Okay. Now the treatment for this is you're just going to give them damn it. You're just going to obtain vital signs. You might put them on the monitor if you're a paramedic. Administer oxygen as needed. What level do we keep the O2 saturation higher than? 94 or higher, okay? Allow the patient to remain sitting in an upright position. If you lay these patients flat, they will go ballistic and maybe even die. So you cannot lay them flat, okay? I'm telling you, you cannot. They won't let you lay them flat, right? They will panic. Be reassuring. Remember, chaos is contagious, so we need to let them know, hey, you're in good hands. We're going to take good care of you, right? We're going to take you to the hospital. Bring the patient's medications. These patients are usually chronically ill, and if they have a history of heart failure. Heart failure is very common, by the way. If you were to run, someone over the age of 60, I mean, a third of them have heart failure of some kind or more, right? Administer nitroglycerin and that's just my opinion. That's an anecdote. I don't know the actual number. Administer nitroglycerin if the patient's systolic blood pressure is above 100 millimeters of mercury. What's the systolic blood pressure? Remember, that's the top number. So, remember, okay. Nitroglycerin causes venous dilation, right? So it increases the capacitance of veins. A lot of the venous blood gets stuck in there, so it decreases the amount of stretch in the heart, decreases oxygen consumption, blah, 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 blah. So the problem is, if someone already has low blood pressure and you give them so think about this, right? When you do that, you're going to decrease cardiac output. By design, you're decreasing cardiac output. So when you do that, you're going to decrease the blood pressure. Well, The consequence of that, if you give this to someone who has a blood pressure of 92 over 50, right, you could drop their blood pressure way too low to where you're no longer perfusing the brain or the kidneys or the heart. You kill them. So you can't admit, as a general rule, you cannot administer nitroglycerin to a patient when their systolic blood pressure is less than 100. Okay, remember systolic, top number. Now, pulmonary edema, I've talked about this. What side, if you were to split the two, what side of heart failure do you get pulmonary edema first? Left-sided heart failure, left lungs, right? Left lung swelling, right? Left pulmonary edema. So you end up with left-sided heart failure will cause pulmonary edema. Now, what I tell my students is when you hear them say the patient has crackles heard on auscultation, you need to think this is a heart attack. So here's what they'll do. They'll say the patient is diaphoretic and anxious, and you notice that they're breathing 32 times a minute, and they have crackles noted on exam. What's the most likely cause of the crackles? It's acute myocardial infarction. That's what it is, okay? Don't pick something crazy like asthma or bronchitis or something stupid, right? I'm telling you, when they tell you the patient has crackles in their lungs, your brain needs to be thinking, this is a heart attack that has now caused heart failure until I can prove otherwise in the vignette. So I'll say that again. When you hear them on an exam, it's coming up. When you hear them on an exam say, the patient has crackles noted on auscultation of the lungs, you need to think this is heart failure that has been caused by a myocardial infarction, acute myocardial infarction, a heart attack, that is now causing left-sided heart failure that's causing pulmonary edema that sounds like crackles, okay? Very important to know that. You will get questions wrong if you do not understand that. Now, pulmonary edema is very severe. This is very threatening, as you can imagine. And the patients are in full panic mode, as they should be. They're dying. And so this can lead to respiratory failure and death. I have seen patients like just ripping their clothes off, grabbing me. They're dying. Like they are literally panicked, right? Like they're truly dying and they know it. And so you have to be worried about that. This is a true medical emergency. Sit them up, put them on oxygen. CPAP, BiPAP is a really great option if you have it, and go to the freaking hospital as quick as possible. Okay. Now, precipitating causes of pulmonary edema, heart failure, namely left-sided heart failure, myocardial infarction. Okay. So working backwards, remember, myocardial infarction causes heart failure. Pulmonary embolism, remember, this is when a blood clot will bust loose and park itself in the pulmonic artery, decrease the perfusion to the lungs, so they'll have clear lung sounds saying they can't breathe, and that's a VQ mismatch, right? Very deadly. And then hypertension. High blood pressure can cause heart failure. We've talked about this, especially left-sided, systemic hypertension causes left-sided heart failure, and when the left side of the heart fails, you end up with pulmonary edema. Cardiomegaly, fancy word. This means big heart, okay? So if someone's born with a big heart or they develop it over their life, there's several reasons why this can happen. You can end up with heart failure or pulmonary edema. Sorry. Also, let me add to this list valve issues. If someone has a heart valve issue, right, you can also end up with pulmonary edema and heart failure. Now, the preload and afterload influence the buildup of pulmonary edema. We've talked about this, right? So there's a lot of ways we can treat this. One of the main hallmarks is to decrease preload. How do we decrease preload? It's with nitroglycerin. So nitroglycerin is a common treatment in heart failure. The other way we'll treat this is with like a mechanical force through CPAP. We've talked about CPAP in the previous chapter, and that's where we shove air down into those alveoli, and we're like pushing, like literally pushing fluid is kind of out, okay, back into the vasculature. So the hallmark of treatment for someone with heart failure, whether you're a paramedic or an EMT, is nitroglycerin and CPAP. At a minimum, oxygen. Like they need oxygen and they need to be sitting up, right? Maintain their airway. The risk of these patients dying in acute pulmonary edema or complete heart failure exacerbation, it's up there. You can die really quickly from this. And at that point, you just go to full-blown CPR. Okay, transport the patient for definitive care. Remember, we're in the business of taking patients to the hospital, take them to the hospital. Okay, now hypertensive emergencies. Remember, hypertension, high blood pressure. So know this definition. It occurs with a systolic blood pressure greater than 180, or a rapid increase in systolic blood pressure, or a diastolic pressure greater than 120 or greater. So if someone's 180 over 100, boom, hypertension. If someone is 175 over 135, boom, hypertension. If someone goes from one, I don't know, 60 to 1 over 100 to 190 over 110, boom, hypertension. Right? So like these are all hypertensive emergencies, okay? Now, what you're going to do is we're limited on our care in this. It's complicated why, but position the patient with the head elevated, okay? Transport rapidly, and we don't establish IV access, but there's medications you can give for this, like beta blockers or hydralazine or labetalol or something like that. But we don't really mess with that very much. It's controversial to lower someone's blood pressure in the pre-hospital environment. Let's just say that. Now, I was totally lost on this in EMT school, so I put a drawing here from one of my textbooks to explain this. So we know that we have this thing called the aorta, right? It comes out of the left ventricle and it loops around like this to the right, and it goes through the abdomen, follows kind of the spine. Okay, it's a really thick artery, a very big artery. Well, it can dissect, okay? And the word dissect, like imagine like a surgeon or like a someone like a pathologist dissecting something. They're being like real microscopic and dissecting something. Well, what happens is, and let's talk about this. So that's dissection, and that's an aneurysm. Okay. Well, what is an aneurysm? So aneurysm is ballooning of a vessel, so it balloons. So imagine you have a water hose, and there's like a big balloon in your water hose, right? That's an aneurysm. So when you hear aneurysm, I want you to think of ballooning of a hose, right? And so this happens in arteries. So this can happen in your brain, or it can happen in your heart, or in your abdomen, right? So you've probably heard of an abdominal aortic aneurysm, right? A triple A. That's a big balloon-shaped mass in your aorta where it's expanded and caused this weakness in the walls. And so it's called an abdominal aortic aneurysm, and it commonly presents as a pulsating mass in the abdomen. And so, think about this. Do you think the walls of your water hose, when it balloons like that, are very strong? They're not. So a few consequences can happen here. Um, the most lethal one, the one where they die like that, is if this just ruptures, if it just pops open, right? If it just straight up just boom, blows up, like they're dead. Okay, not a lot you can do for that. They'll die within a minute or two. Okay, if in the abdomen, right? Like it's over. It's in the brain too. You're gonna have a stroke and probably die. So that's the most severe case of this. Okay, but of course, this is medicine, right? There is a more annoying case that happens where we can get what's called a dissecting aneurysm. So you should know that right here in these walls is the weakest point. And so what can happen is this is made up of layers, right? So I could draw it like this. We should know that these hoses are made up of layers, right? And so what happens is you can end up with this layer like opening up right here. Whoops. Sorry, hold on. It can dissect like this. Well, what happens is, keep in mind, there's blood flowing through here. Blood can like whip through here, especially because it's turbulent in here. It can whip through here, and so it can start pulling the layers of the aorta apart. Okay, so instead of like being this bilaminar, right, it starts ballooning like this. So now this whole area up in here is filled with blood. So we have these three layers: tunica intima, the tunica media, and the tunica externa, or the adventitia. And so what happens is you end up with like blood leaking up in the layers of the aorta. And so this creates this huge problem. So it literally tears it. And that's what it looks like on here, right? So, you can imagine there's they show it to you here, a little tear here. And now you end up with blood like leaking up on this layer between the middle layer and the external layer. Let me think about that. Yeah, no, it's between the inner layer and the middle layer, actually. And so you end up with this dissection. And how this commonly presents, and so you don't need to know these classifications, the DeBakey classification, but what happens is this can progress, right? And it can go all the way down the aorta, and like this can hold a lot of blood, and it's very painful, and eventually this will rupture, right? Like you could imagine, again, if this is a water hose and you start like popping fluid between the layers, it's going to blow up, right? And so that can happen, and you end up with death, right? Like so, if these pop, boom, dead. Minutes, like a minute or two, like completely dead, kapooey, put an IV in them, they're done. So that we don't want that to happen, so we watch for this. And you're like, okay, Hunter, like quit your nonsense. Well, the reason I'm telling you this is this presents with a very specific well, academically, not in real life, but on exams, this will present it with a specific phrase. And what they'll tell you is the patient has a tearing sensation between their shoulder blades. Because where's your aorta? It runs right through the center of you. So what they do is they literally feel this dissecting and tearing. And what it feels like to your brain, how it interprets this pain, is it feels like it's tearing between your shoulder blades, a dissecting aortic aneurysm. And so that's what this is. Okay, if you catch this in an early enough stage, like here maybe, sometimes the surgeons can come in here and fix this, right? Hopefully, if they catch it quick enough, and if they got big cojones, right? This is a very risky procedure, and so you can fix this. But again, if these pop, like boom, dead, like there, and I've had this happen to me. So you might ask yourself, well, what causes this, right? Like, oh, and another way this will present before I go to that is unequal blood pressure in the arms. Okay, there's vessels like here and here, and like there's different vessels, right, that will go to the left arm and the right arm. Well, if you like tear, like for example, right here, like if you were to tear this one, but this one's still intact, you'll have a difference in blood pressure is greater than 10 millimeters of mercury in each arm. So how this can present is I'll tell you patient has tearing sensation between the shoulder blades. Blood pressure on the right is 170 over 100. Blood pressure on the left is 50 over 40 or 50 over 60. I'm sorry, 150 over 60. I go, wow, that's like a big pressure difference, right? It should be no more than 5 between each arm, millimeters of mercury. So you're like, oh, wow, huge pressure difference in the arm. You should be thinking like dissecting aortic aneurysm, okay? Now, the primary cause of this, again, is uncontrolled hypertension. Again, guys, if you put a water pressure underneath really high pressure, it's going to fail. It's going to get all torn up and fractured and micro tears, right? So again, how this presents is sudden chest pain. They might even describe it as, interior chest pain or tearing pain between the shoulder blades. If you hear pain between the shoulder blades, you need to think that's a AAA. That's the answer. Pick it. What's the most common cause of this? Uncontrolled hypertension. Okay. How else can it present? Unequal blood pressure between the two arms. Now, patient assessment, right? This is where we're going to zoom through the rest of this, okay? So, we do a good assessment. We look for, we recognize that reperfusion is the goal, not sitting on scene doing nonsense garbage. The goal is to get them to the hospital so they can go to a cath lab and see a doctor, okay? So load them up and go, okay? Get their medication list, load them up, go. Now, ensure that you're safe. Of course, we don't get reckless loading up. Everyone needs to stay safe, including the patient and you. Make sure you're safe. Look for hazards. Determine number of patients. Do you need additional resources? Do you need ALS intercept? Do you need to fly this patient if you're in a rural area? Identify the nature of the illness. It's probably going to be chest pain, right? Form a general impression of the patient's condition to recognize and address the life threats, okay? We want to do a quick, rapid, right? A rapid full body scan of the patient. Do a full body scan of these patients. I'm telling you, you will find things that you didn't expect. I'm telling you earlier about pedal edema where you'll see like swelling in the feet. That's for patients that are sitting up. Patients that are laying in a nursing home bed, where do they swell? Remember, gravity is what causes this. They'll swell on their sacrum, right above their butt crack, right? So sacrum, it'll swell. So you need to do a full exam, including their back, right? If the patient is pulseless, apneic, and unresponsive, holy cow, we do CPR, okay? Assess for any major bleeding or edema. Okay, determine the rate, quality, and degree of the distress of the respirations. We qualify that, right? So instead of just saying they're breathing good or bad, right? We say they're breathing 22 times a minute in labored. They're tachypnic, taking shallow breaths. There's crackles noted on auscultation with accessory muscle usage, right? Like I just painted a lot better picture in your head, and that's what you need to be doing in your reports and in your chart. Consider the use of CPAP. When do we use CPAP with chest pain? Or in cardiovascular emergencies? It's in heart failure that causes pulmonary edema. What size, if we were to isolate the two, what side causes pulmonary edema? It's the left side causes lung edema, right? Left lung. So do know that. Now, you assess the circulation. How can we assess circulation? Peripheral pulse points, capillary refill, okay? Make a transport decision based on whether life threats have been stabilized, right? So if you're 5 minutes from the local hospital that doesn't have a cath lab team, but you're 10 minutes from the hospital that does have a cath lab team, you probably need to go to the cath lab team in most scenarios, unless they're dead, okay? Now, history taking, determine and investigate the chief complaint and history of the present illness, okay? I'm reading these to you because I feel like they're kind of obvious, and you can read these to yourself. So but we're not done. We have a few more slides at the end. A chief complaint of chest pain or discomfort, shortness of breath, or dizziness should be taken seriously. So, let me tell you this. Very important to know. Words of wisdom here. Women and diabetics present with abnormal chest pain, right? Abnormal acute coronary syndromes. So they may just say, I feel weak and dizzy. They don't mention shit about pain. And you're like, oh, okay, they're weak and dizzy. That could be a billion things. But you need to be thinking, especially in women and diabetics, not my opinion, academically, women and diabetics present abnormally in acute coronary syndrome. So you need to be thinking, oh, wow, this could be a lot of things. And at the top of your list, it needs to be acute coronary syndrome, and you need to be working backwards from that. It is that until proven otherwise. Okay? Now, determine whether the patient is experiencing chest pain or discomfort or any respiratory difficulty. Who presents in the absence of these symptoms? I just told you, women and diabetics. They may not have pain. Okay? Now, ask about other common signs and symptoms. We're going to take them sample history. We're going to look for medication allergies, get their medical history, medications, right? We do a pain assessment, right? Onset, provocation, quality, radiation, severity, time. I don't know what the I stands for. I'm not looking it up. Now, ask specific questions. So these are good questions we could on our focused assessment where we're trying to narrow down our interview techniques, right? So remember, we started with what's going on today, we start with there and we will get a little bit more specific as we go. But have you ever had a heart attack or have been told that you have heart problems, right? Do you have diabetes or do you have problems with your blood sugar? Have you ever had kidney disease, right? So you got to be careful. Sometimes you'll be like, do you have any medical problems? They're like, no, right? And then they are taking 10 medications and they have dialysis 3 days a week. And you're like, wait, I thought you had no medical problems. They're like, no, I don't have any problems. I'm taking care of them, right? So sometimes you have to probe these patients, okay? Do you have any risk factors for coronary artery disease, such as smoking, high blood pressure, or high stress lifestyle? These are all modifiable risk factors that increase the risk of coronary artery disease. We've talked about that. Now, you're going to evaluate the person's circulation. This can be done through peripheral pulse points or capillary refill. Okay. Assess for signs of inadequate ventilation. Remember, just because someone's breathing 24 times a minute like this, that's not adequate, right? So it needs to be adequate. They're moving good tidal volume. They're actually ventilating, okay? Assess the level of consciousness, okay? We could look for their alertness. Do you know where you're at? Do you know what's going on? Where do you live? I hate this question, who's the president, right? You could do things like that. What's today's date, right? Measure and record the patient's vital signs and their mental status. Obtain the blood pressure readings in both arms, right? Which pathology, it says, will cause an abnormal blood pressure reading in arms? Aortic aneurysm, okay? How does aortic aneurysm present? Tearing pain between the shoulders. What causes it? Uncontrolled high blood pressure. Very fatal if it's not caught. Now, so we reassess, okay? I'm not going to explain that to you. Now, the emergency medical care for chest pain or discomfort, okay? Treatment begins when we get there, right? Properly positioning the patient. Again, don't let this patient lay flat. They're not going to let you lay flat if they're conscious, okay? Provide assistance with breathing as needed. Okay, cool. It's at the top of the list. Circulation, airway, breathing, right? Obtaining 12 lead EKG in the first 10 minutes. Even EMTs should be, you're not going to interpret the 12 lead, but you a lot of times will put it on and transmit it to the hospital. So the monitor will, you're not expected as an EMT to know how to read the reading, right? But you should be able to put this on for your paramedic partner, or at a minimum, just put it on and hit send and send it to the hospital. You could gain IV access, but that's advanced EMT. And prepare to administer aspirin and assist with nitroglycerin. So let's talk about these drugs, okay? So administering nitroglycerin, remember, we have the rights in medication administration, right? Right patient, right route, right indication, right order, right if they don't have the allergies. Don't get me caught lying on the routes, but you know what I'm saying? So you're going to administer nitroglycerin if your local protocol allows it, you believe their chest pain is cardiac in nature, and their blood pressure is greater than 100, the systolic blood pressure. So you need to wear gloves when touching nitroglycerin, even the tablets, okay? It will dissolve straight through your skin and affect you if you're not wearing gloves, even the tablets. And you're going to obtain permission from medical control to administer it, or you're going to give the patient their prescribed nitroglycerin. You can give this once every 5 minutes. I'm going to make a separate video on nitroglycerin, like a drug video that you're going to have to memorize. And then you're going to follow local protocols for administration of additional doses of nitroglycerin. So you can typically re-administer this every 5 minutes with a maximum of 3 doses, okay? Now, a few things to add about nitroglycerin. It expires really quickly. And it's unstable, right? Not like unstable like it's going to blow up, but it's unstable is then like it's sensitive to like moisture, humidity, and especially light. So do keep that in mind. So if the patient, okay, I'll give you a scenario. Just a test question. You arrive on scene, the patient's taking 3 nitroglycerin with no relief. You look at their nitroglycerin expired 10 years ago, and it looks like the pills are decayed into powder. What should you do? You should go ahead and administer the three more in-date nitroglycerin. Okay, this happens a lot actually, where you'll get on scene and the patient's taking their nitroglycerin, but it expired like 2 years ago. So, or it's been floating around in their purse and it's like just pulverized or like it's not good. So just be aware of that. Remember, nitroglycerin causes venous vasodilation, which will decrease preload, which decreases the stretch of the ventricle, and then that will decrease the amount of oxygen or ATP needed. And remember, we make ATP and cellular respiration and electron transport chain with the ingredients of glucose and oxygen, and to create ATP. So the idea is let's use less ATP because we have less oxygen, and you do cause less stretch to the heart. So Frank Starling law doesn't have to work as hard, so you don't have to squeeze as hard to require as much ATP. So you do need to know that. Okay, the dose of nitroglycerin is 0.4 milligrams sublingually. Okay, and you can give this, times 3 Q5 mins, right? Every 5 minutes. So it's 0.4 milligrams in each tablet. You give it sublingually underneath the tongue to let it dissolve. Do not have the patient swallow it. It will not work. The stomach will destroy it immediately. And you can do this 3 times every 5 minutes, right? So that's how this order would be written. Very common. Remember, this can also be given in a paste and in spray in the mouth too. So you can spray this in the patient's mouth. You can give them like a little dissolving tablet under the tongue, that's sublingual, or you can put it on their skin as a paste. It's measured by the inch. You give an inch. Now, let's talk about aspirin because we just like blew over that. What's aspirin? Let me use this page. What's aspirin, right? Acetylsalicylic acid. Well, aspirin is a platelet aggregation inhibitor. Okay, so let's think about this. This is a vessel. Here's a big old clot. What makes up this clot, one of the many components, is platelets. And as additional platelets in the blood come floating by, they're going to grab onto the other platelets. Well, what you can do when there's aspirin in the equation, you take these platelets and you make them less sticky. The platelets don't decrease; they don't stick as well to other platelets. So the reason we do this is because if platelets were to keep lining up with no aspirin, right? They keep sticking together. You can decrease the lumen of this vessel, right? And that causes, a smaller lumen, so less blood flow, right? So that increases the damage. And so the reason that this becomes an issue is uh, the reason we give aspirin is to prevent these platelets from like holding on to each other, right? So like, imagine like platelets like buddies like with their arms out, right? And as soon as like they swing by, they're like, oh, hey, what's up? And they just grab each other and they hold on to each other until they form a clot. And that's what's supposed to happen. But if you give aspirin, that gets inhibited, right? You kind of like put, like instead of making hands for them to grab each other, their hands are kind of fist up to where they can't grab each other, right? So they don't aggregate. So, test question is aspirin a blood thinner? No, it's not. Is aspirin a platelet aggregation inhibitor? It is. Okay. It's also used for pain, of course. It decreases cyclooxygenase, or arachidonic acid pathway. But what's interesting about aspirin? This is interesting, right? Even as a paramedic or a physician, well, maybe not as a physician, but even as a paramedic, if I were to tell you that as a paramedic we give nitroglycerin and we give morphine and we give aspirin, and we might even give the beta blocker, and all these medications and do 12 leads. Of those, pick one that is proven clinically to actually save lives and reduce morbidity and mortality, right? It's aspirin. So aspirin is the only one of all the treatment that you will give, not oxygen, not patient positioning, not nitroglycerin, but aspirin is the only one that is clinically proven to decrease morbidity and mortality in acute coronary syndrome. Okay, so this is a very important one to give. Now, a few caveats with this. The dose is 324 milligrams. Okay, usually have the patient chew this up and we'll let them swallow it, or they'll give them like 3 baby aspirin. And so, or wait, yeah, 3 or 4 baby aspirin. And I think that's 4. No, it's 3. I've been out of the field for a while. So what you do is you have them chew them up. And so the dose is 324 though, for sure. The idea of this is to decrease platelet aggregation. And so where I'm getting at with this is, like, say the patient's like, oh, I take a baby aspirin every day, which is 81 milligrams. You're still going to dose the patient up to the 324. And a lot of times you'll give 324 anyways. So you'll give all three baby aspirin, right? That's the standard of care, right? A lot of times you won't just, if the patient's like, I've already taken a single baby aspirin, like they haven't got to the 324, or it's like 10 o'clock at night and they took 324 milligrams of aspirin that morning when they first woke up, which is rare. You just redose the aspirin is the standard. Okay, it's like, to overdose on aspirin is very difficult, although possible, and not good when it happens. But what I'm saying is, when in doubt, give aspirin because it saves lives. Okay, and it's really weird to think like a drug as benign as just stinky old aspirin saves lives when nitroglycerin and morphine and lights and sirens and cool shit doesn't. Right? It's really weird. So paramedics struggle with that, and they tend to write off aspirin as like, oh, it's just aspirin. Okay. Now, a few things to consider with aspirin is, since it does increase the risk of bleeding, it's not a blood thinner, but increases the risk of bleeding, is you generally don't want to give it to someone who is actively bleeding, like with a GI bleed, right? So if someone tells you like, oh, I'm vomiting blood or pooping blood, you really typically don't give aspirin. Okay. That's a contraindication. Uh, and so you need to call your doctor and say, hey, patient told me that they're pooping blood for the last week. What do you want me to do? Right. And they'll tell you what to do. But sometimes we don't give it. Now, what they're showing you here, that's the aspirin spill, okay? Now, what they're showing you here is like what's called a zipper, or cardiac zipper, like a zipper on a coat, because it goes midline. And so this is like, they're not as big as this anymore, but this is like someone was open from here to here and they had a very invasive cardiac surgery. And so, you see where there's trocars down here or whatever, but this is a big deal. Like this doesn't happen as much anymore, but it certainly happens. So something to look for in a patient, you're like, oh, I wonder if the patient has heart failure. Open up their chest when you're doing your 12 lead. If there's a zipper from here to here, they got heart problems. Okay, what that is varies, but they've had open heart surgery, right? Like they've had a coronary artery bypass graft or heart valve replacement, or something's happened. And this is what I just said: coronary artery bypass grafts, and this is also called, not to be confused with the German food of cabbage, but it's called a cabbage. Coronary artery bypass graft. So you'll hear people call this a cabbage. So don't be the guy that's like, what, a cabbage, coleslaw? So cabbage is where we will take another. It's weird, right? We replace an artery with a vein. We'll take a vein somewhere else. Usually it's down on the leg, like the saphenous vein, and we'll take it and we will graft it up into the jacked up coronary artery. So what we'll do is we harvest veins from somewhere else in the body, doesn't matter where, and we'll pick that. Not we, but like surgeons, like very advanced surgeons, and they'll pick that up and they'll move it up into the heart and remove that damaged, blocked, jacked up, hardened part of the heart, and they'll replace it. And so you've probably heard something like, "Oh, I've had a triple or quadruple bypass." Well, what they're saying, is they've had 3 triple or 4 quadruple of their heart coronary arteries replaced with a vessel that was found somewhere else in their body. This is obviously very big, right? So, like, a big deal when this happens. This is a very invasive surgery. But, it happens. It's pretty common. People have good outcomes from this now. They're getting better and better at this. So, percutaneous transluminal coronary angioplasty dilates the coronary artery. Remember angioplasty? That's balloons, right? To where we go in there with a balloon and we kind of, like, we just kind of blow it up. Not like explode, but we expand it, right? And so that's angioplasty. We're getting to the end. Now, a pacemaker, you see these quite a bit. Typically, these will sit on the left side of the chest right here, okay? And you can feel them. You can actually see, like, usually I'm on a patient's shirt, you'll see it, right? But I want you to know they can be on the right side, okay? But typically, it feels like a deck of cards underneath here, to where a lot of times, like, if I don't, you should, as an EMT, we should, if I don't, I'll just feel right there, right? Like, with consent, I'll just, like, rub my hand on that, and you feel them, okay? It's like you feel like a deck of cards underneath your skin. So basically, when the electrical conduction system of the heart gets damaged, you'll set a pacemaker. What's a pacemaker? It sets the pace, just like a pacemaker of a race, right? Like you set the pace of the race, right? You got to set your pace. So that's what happens here. And what happens is there's like a couple wires that'll come off and attach to the heart in different places, to where it replaces the SA node and the AV node and all that shit with this, okay? And this is, there's one right here, and you can actually see the wires coming off, and they're implanted here. So This is a pacemaker implanted in someone's heart, and you can see where the leads are at right here. Okay. And this is actually another one too called an AICD, or an automatic internal or implantable cardiac defibrillator, right? AICD. And so this is a defibrillator, just like an AED, an automatic external defibrillator. This one's internal, it's implanted, right? And so what you can have, this happens more common, is you'll have a pacemaker AICD combo to where when you feel up underneath their skin, it just feels like this. It feels like a deck of cards up underneath their skin. But it's both a pacemaker to where it'll set the pace, and if their heart gets out of whack and it starts doing like the weird stuff it's not supposed to be doing that's lethal, it'll zap them and it'll pop it right back into place. So it's usually for patients that go into ventricular fibrillation, which is when the bottom of the heart just quivers and it looks like this on the EKG. I showed you this earlier. And so the bottom of the heart, instead of going like boom, 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 the bottom of the heart's just shaking like this, and you'll die within like a minute of this happening. This is lethal, right? Very lethal. It's cardiac arrest. They won't have a pulse or be breathing when that happens. So, some genius, very smart, was like, well, let's just implant an AED inside them. We'll just make them wear it at all times, and if they go into ventricular fibrillation, instead of putting an external AED and hoping someone puts it on them, we'll just pop that puppy in their chest. Now, I will say a distinguishment. Patients don't feel pacemakers, right? They don't feel this good firing, right? And sometimes these will fire, sometimes they won't, sometimes they're demand pacing, right? All that's not important. But they can, not always, they can feel it when they get defibrillated because it's much more electricity. So if you have a patient that's saying like, I felt it, I've ran a call or like several calls where they're like, oh, I felt it go off 5 times since dinner, right? It's like 2 hours later. You're like, holy crap, you should have called earlier, right? So their heart's messed up. So they need to go to the hospital like right now. So that happens when they'll tell you, no, I felt it go off 3 times, or I felt it go off, right? So as you can imagine, getting defibrillated from the inside, like clear, right? It's not pleasant. So they typically will feel this. They'll feel it when they get defibrillated. They do not feel pacemakers typically. They shouldn't, unless there's like a issue. Now, the external defibrillator vest, they call these life vest. Sounds like what it sounds. Like an AED, right? Pad here, what they do is it's like a vest that the patient will just wear. And what it is they're waiting to get this thing installed. So this is like to buy them some time. Now, an LVAD, or a left ventricular assist device. So remember, left side of heart failure is a big deal because you have to be able to eject blood out up to your head and down to your big toe and be able to pump it out of the lungs. So what happens is someone came up with the device that said, well, the left ventricle is only beating at like 30% of what it's supposed to beat, its efficiency. Well, what if we just add like a little supplemental pump, a little help you out, right? To where it's like an impeller pump. It's like, and it's an external device that they wear, like a satchel, like a man purse or something, that connects to their heart. Crazy, right? That helps their heart pump. Now, what's interesting about an LVAD is if a lot of times they will not have a pulse or no BP. And you're like, what? But they're alive, right? Because think about what a pulse is. It's contraction, right? But when it's just like an impeller, right, pumping, you won't feel that. Okay. We're going to zoom through cardiac arrest because we've covered this in class, but I'll cover it really quick for you, right? So cardiac arrest is indicated by the absence of a carotid pulse. Remember, carotid pulse is here. Can also be indicated by the absence of breathing without a detectable pulse anywhere, right? So if they tell you the patient doesn't have a pulse but they're breathing, start CPR, okay? Because they could be gasping, okay? Patient was choking on brisket and barbecue, and you cannot palpate a pulse, start CPR, okay? So anytime you cannot palpate a pulse, start CPR, especially a carotid pulse, okay? Now, of course, we know what AEDs are. I'm not going to talk about that. Just know that I'm not going to test you on this, but most of them are biphasic now, right? To where it's like pa-ching, pa-ching, right? To where it's sending direct electricity in 2 directions, right? It's safer. Uses less electricity, so it makes it safer. So basically, you put these on a patient and it recognizes the rhythm. There's only 2 rhythms it shops. It's ventricular fibrillation or ventricular tachycardia. So remember, VFib is when it looks like this on the EKG. The bottom of the heart's just quivering. And VTAC actually looks like this. And so the bottom of the heart, the ventricles, are beating like 200 times a minute. and that's not very effective. So sometimes it won't have a pulse, or it's just like what they call pulseless electrical activity. And anyways, it's these are deadly, right? You don't have a pulse, okay? So they die. So we know what saves lives in cardiac arrest is early access to defibrillation, i.e., putting on an AED and letting them ride the lightning if they need it, and access to high quality chest compressions, right? Early access to high quality chest compressions, right? That's it. That's what we know for a fact saves lives. It's not epinephrine, it's not IVs, it's not lights and sirens, it's not cool intubation and King Airways and eye gels, and it's not all that. It's not. The literature is very clear on this right now. What saves lives is early access to defibrillation and high quality chest compressions. It's not the BVMs. It's not, right? So it's very interesting, again, when we look at, well, what does the literature very clearly say is saving lives? It's stuff that's not very sexy, right? Like giving aspirin is not very like, woohoo, look at me, right? Like this is awesome, right? It's necessary, right? But same thing, right? Doing just straight up chest compressions and throwing on an AED is not very complicated. But like intubating someone and throwing in a King Airway and using a BVM and start drilling a needle into their bones, give epinephrine and lidocaine and amiodarone and all these drugs, it's really sexy and cool. It's not what's saving lives, and that's what's really interesting. So it's just a interesting paradigm. Anyways, there's these 6 links to the chain of survival. I've seen these pop up very rarely on exams, so I'll say it very quick. Recognition of early warning signs and immediate activation of EMS. Immediate CPR with emphasis on high quality chest compressions. There ain't no shame in Hunter Harbold's game. I can do this for like 2 minutes, right? And appropriately do it for 2 minutes. So if I'm worn out, someone else needs to like tag me in. And if you're sucking at chest compressions, I'm going to say, hey, yo, Jeff, you look like you're tired. Let's trade out. And he's not going to take offense to that. Okay? He's going to be like, let's do it because we're here for the patient, right? So sometimes in the moment, you may think, oh, I'm doing good chest compressions, but you're exhausted. I'm telling you, I hope the day comes. I mean, unfortunately for the patient, where you get to say, like, help someone on their very worst day and do chest compressions. It's exhausting. Okay? I'm in great shape. It's exhausting to do this. Just be aware of that. Now, rapid defibrillation, we talked about that. Basic and advanced AMS care, ALS, and post-arrest care. So sometimes we get them back and, it's like, well, God, we got a pulse back. Now what, right? Like that's a whole nother discussion, right? And that's very complicated. And then recovery. Like, so this is the 6 links in the chain of survival. These are AHA coined terms. We'll do a CPR class here pretty soon if we haven't done already. And we cover this like over and over again in a CPR class. So don't panic. If you haven't been taught this, you will. So you should know how the AED works. We've talked about this. I get tired saying this, right? But let me say this. The error of an AED is not the machine, right? It's failure to properly charge or maintain the AED. So the batteries are dead, the pads are expired, the pads are missing, something like that. It's been misplaced. Or the application of an AED to a patient with a pulse. So again, the AED can't tell if they have a pulse or not, but it doesn't really matter because in either one of those rhythms, if they get defibrillated, it won't cause harm. Okay, remember the rules of medicine: do no harm and do no harm. So yeah, I'm not going to talk about the checklist on that. So well, how do we do CPR? And this is not a CPR class, so I really should have deleted these slides. But you're going to push hard and fast in the center of the chest at a rate between 120 or 100 and 120, and you're going to allow full chest recoil. So you're going to allow the chest to come all the way up. Compression should not be interrupted unless absolutely necessary. So what that looks like is 28, 29, 30, ventilation, and then boom, Jeff's taken over, right? So you trade off in between cycles when ventilations are occurring. Do not defibrillate a patient in pooled water. Okay, yeah, electricity and water, especially pooled water, don't mix. Remove nitroglycerin or other medication patches. It's been tested over and over again. They won't explode, but it is a best practice to remove them. Be careful when you remove these. These will go right through your skin. Make sure you're wearing gloves. You shave a hairy chest. This actually is important. If you have like a male with a very hairy chest, the pads won't properly sit on the skin and make contact. So all AEDs will have razors in them, or they're required to have an additional set of pads. So your option is to put the pads on and wax their chest and pull them off and put a new set on, or you can shave their chest really quick. And I'm not talking like a careful shave. I'm talking like you're shaving the shit out of their chest because they're dead, right? So you move very quickly. You're not worried about nicking their skin a little bit. Perform defibrillation. So, if it tells you, stand clear, analyzing, everybody let go, right? It's analyzing, it's shock advised. Okay, it's going to charge. Really, you should be doing CPR while it's charging. And then, all right, everyone clear. You look around, make sure everyone's truly not touching the patient. All clear. Boom, shock delivered right back on the chest. Don't care what you think. Right back on the chest. Boom, shock delivered. Immediately begin CPR. They're not coming back like in the movies. You need to start another round of CPR. Okay? Now, you know, I hate that I'm even going over this with y'all because we're going to cover this in class. But here's an algorithm. I'll move my face out of the way if you want to screenshot this. This is in your book. This is very easy. You know, we're going to run quite a few cardiac arrest in class to where you're going to be like, oh, I got this, right? Like it's you'll notice if you do this like 2 or 3 times in a row, you'll be like, this is easy, right? It's very algorithmic. Oh, we check for a pulse, they're not breathing, start CPR. Someone get the AED, we apply the AED, we do a 30-to-2 ratio, right? Like we do a rhythm check every 2 minutes, right? Like it's easy, especially with an AED, it tells you what to do. So don't worry, it's okay. Um, if you hate on me for not going over this, I just don't think it's good use of our time. So that's pretty much it. Now, the last 2 slides are important, okay? Now, again, do EMTs interpret EKG rhythms, ECG rhythms, cardiac rhythms? They don't. Okay, I'm not training you to do that. That's a paramedic school thing. It's very complicated. Now, what you do is you apply the electrodes, like you put them on what's called the monitor. So I do need you to know how to do that. And so what that looks like is, you know, this is complicated. I'm not going to ask you where these go, by the way. Okay. In the real world, they're labeled like right arm, right leg, left arm, left leg, and they are color coded, but it's written on there. Like it'll literally say like right arm, like written on the electrode or the lead. And so basically, what you do is you attach these things called electrodes, and they're like little like Band-Aid foamy looking things with a gel on them. To where you've probably seen this, and you stick it on the lead, right, and then you stick that on the patient's skin and designator. There's a few points I want to make on this, and then we're going to end this because I'm tired too. First is that bone does not conduct electricity very well. So you want to place this generally over an area of muscle because muscle does conduct electricity well. So the deltoids is an all-time favorite for me. It's out of the way. You can, the blood pressure cuff's going to be here. Someone might be starting an IV or doing something down here. So deltoids are a really good place to put these. And then you should ideally put these somewhere on the limbs. I like doing it on the inner thighs. Okay, but it needs to be bilateral. So what does that mean, right? Like you can't put the electrode here on this side and the electrode here on that side. They need to be at the same level. Okay. Now, what you'll see on the ambulance a lot is sometimes they'll put this like up on the obliques. That's between you and your maker. I don't care. But I'm guilty of this. The reason you do that is the closer you move this into the heart, the less artifacts, so the less like interference you get on your tracing. So the closer you move these into your heart, as opposed to like if I had these like on my like right here on my forearm and down by my ankles, you're gonna get a lot of interference. It doesn't make it wrong. It's really the way it was designed to work. But if you move it in a little bit better, it works a little better. So we'll show you in class how to do this. Okay, you need to know how to do this. Not how to interpret the reading, but you need to know how to put someone on the monitor because I guarantee you when you go on your ambulance ride outs, they're going to look at you and say, student, put them on the monitor. So you're going to have to put them on the SP, on the pulse oximetry, get a blood pressure with the machine, and put them on the EKG and maybe do a 12 lead, which is this slide right here. So same thing, you have to shave the chest. Sometimes these electrodes need to make full contact with the skin, not with the hair. And so, what you'll do is you place the electrodes on the skin, and where these go is very particular, but when all electrodes are in place, you're going to print it. So it'll ask you, you'll hit 12 lead, and it'll ask you male or female and the age. So you'll be like, okay, it's a 68-year-old male. And then you'll click it, and you're going to tell the patient, hold real still, don't talk or move. You can breathe like normal. I'm going to take a picture of your heart. It's going to take about 10 seconds, right? And so the patient will sit there and, that's my spiel. Hold real still, don't talk or don't move. Breathe like normal. I'm going to take a picture of your heart, right? And so it takes about 10 seconds, and it takes a tracing of their heart. It's not like an actual cha-ching picture, but it takes a tracing. And so where these go, let me move this, is important. I'm not going to test you on these, but it's something you're going to need to know for your ambulance ride outs. And if you don't know, it's okay to be like, hey, I don't remember exactly where these go. Can you help me, right? And they may show you where them go or point, like put one here, put one here, put one there. So, how I do this is the same way every time. Let me bring my camera down. So how they go is, so keep in mind, my camera's backwards, okay? But on my right, okay, you go V1, V2. And V1 and V2 are in the fourth intercostal space. So this is the second intercostal space. As soon as you get down to the clavicle, you're already in the second intercostal space. So it's one, two, three, four. So right about here is where I'm going to put electrode V1 on my right side, V2 on the left side. That's what they're showing you right here. You could screenshot this if you want. And then what I do next, and this is going to sound weird, is I do V4. Like, what? You skip V3. I'll come back to that. I do V4 and V6 next. So on my left over here, V4 is in the fifth intercostal space, mid-clavicular line. So it's kind of below where the nipple's supposed to be. So you'll feel a fold of the breast. I go right up in that fold right there. And it's typically below where the nipple's supposed to be, or mid-clavicular means you draw the clavicle in half. So it's like right here. So I go right there. That's where V4 goes. V6 follows that same line, but it's mid-axillary. So it's right here. So let's recap. V1, V2 at the fourth intercostal space, peristernal. V4, mid-clavicular, fifth intercostal space. V6, mid-axillary, fifth intercostal space. And you're like, oh, okay. Well, V3 and V5 just fill in the gaps here and here. That's how it works. That's how I do it. So we'll practice on this in class. Usually we can find like a male student who's not afraid to take off their shirt and just put them on the patient. And we'll take a free EKG of you and give it to you. And hopefully it's not bad. And hopefully we don't embarrass you. But yeah, this is helpful to just do it a couple times. And again, you're not expected to be able to understand how to read these, but you are expected on your clinicals. They will expect you, hey, EMT student, put them on a monitor. You do a lot of this. It's very easy, but you know, if you haven't done it before. Now with that, let me add a few things and we're going to end this because I'm tired. You have to have consent for any part of treatment. We know that, right? But just be mindful when you do this with females, okay? So a female's breast will usually sag where V4, 5, and 6, especially V4 and 5, are supposed to go. So what you have to do is you have to usually, with the back of your hand, lift the breast. You know, first off, ma'am, is it okay if I lift your breast? Yeah. So you would lift up their breast with the back of your hand. Do not cup their breast, right? So with the back of their hand, and you would place the electrode, and you could lower the breast back over the electrodes while it takes the picture. It's fine. You have to have consent for this, okay? Don't lose that consent and don't lose this privilege and trust that the patients trust our profession with. Remember, it's all just folds of skin. We're professionals, you know. It is what it is. A few things that I'll say too is a female's bra will get in the way a lot of times with this. So you might have to work around it or have them remove it. You know, there's variance in that. That's a long discussion. You should always have a chaperone, preferably of the opposite sex, but always a chaperone with you when you're placing these. So if it's two males, then you should have two males back there. Don't do this by yourself, okay? Especially if it's someone of the opposite sex. So like if it was me placing this on a female patient, especially when they're around your age, I mean, guys, there's just, I mean, you know what I'm saying? You just got to be careful. It's 2023, almost 2024. So, you know, just realize it's a privilege to treat patients and we need to treat it that way. So with that, I think that's it. Yeah, that's it. So I appreciate y'all's time. That's chapter 18, cardiovascular. I'm probably going to make a video or definitely a drug handout on aspirin and nitroglycerin. And you're going to have a drug test on those. And you're going to need to know everything about those. So you're going to have to know, like, what's the contraindications? When do we give it? What's the dose? You know, what's the route of administration? How often can you dose it? It's not complicated, but it's things that you really actually need to know. And you need to be able to know them in your sleep. So, all right, I'm rambling. That's it. Have a good